Once upon a time, I was a chaplain at Children's Hospital at Stanford in Palo Alto, California. At that time, Stanford Children's Hospital was pretty much a hospital for dying children. There was a unit for brain tumors, another unit for hematology oncology, another unit for cystic fibrosis, and so on. The time that I spent there taught me a lot about death and dying, and about life and living. It also taught me something about how to talk with kids who are dying. Cystic fibrosis has always struck me as a particularly difficult illness, partly because most of its sufferers are quite young, and partly because it affects families so, and partly because it has so many associated problems connected with it, and partly because all of these kids need to be prepared to die fairly soon. And conversations with kids, particularly teenagers, about their own death is a very difficult and traumatic conversation. So for all of those reasons, dealing with kids with cystic fibrosis has been a real challenge. And it can really tear your heartstrings. And it can get to you in ways that other things often don't. For healthcare workers, for example, they typically have long-term relationships with these kids. They're in the hospital, out of the hospital, back in the hospital. They need all kinds of treatments. Bonds form between the kids and their caregivers. And the caregivers live this with the kids. And when the time finally comes that this child is not going to leave the hospital again, it's a really tearing moment for the people who have been doing their best to take care of him and extend his life. Back in the days when I was working with kids with cystic fibrosis, they seldom lived to be 20 years old. It was not at all unusual for them to die in their teens, and very unusual for one to get old enough to graduate from high school, to marry. None of them that I recall ever had children. They were robbed of so much of what most kids look forward to. Their illness incapacitated them in many different ways. The treatments took a lot of their time and sapped their energy, and they knew that they were probably not going to get to do the things that all of their peers were going to get to do. Go to college, get married, have a job, have children. Things have changed quite a lot since then. Now, typically, someone diagnosed with CF will live to be about 40 or so, some even more. New treatments, including lung transplants, have made extra years possible. It's still a difficult time, no question about it, but at least it gives kids a little more time to prepare for the inevitable. And that is the really difficult thing about dealing with kids with cystic fibrosis. You have this very small window in which it's necessary to get ready to die. And there's lots of grieving to be done at a very young age. One of the realities of human life is that all human beings die. The mortality rate for humanity is, and always has been, and always will be, 100%. But most of us don't like thinking about that. One of the benefits of getting old is that your friends die and you realize that time is getting shorter, and your aches and your pains and your aging body makes you realize that you probably don't want to live forever, even if you could. And so you kind of gradually, in older age, get used to the idea of dying. But with a disease like CF, there's not much time to get reconciled to the idea of dying. And many of these kids don't have the life experience necessary to help them to figure out how to do that. So one of the jobs that we have to do in healthcare is to help these kids get used to the idea, get ready for the idea that they are in fact going to die. Now we can't force that on them, obviously, but we can help them to think about it, which is obviously something that they're probably thinking about anyway, since they know more about CF than most of their caregivers do. Another thing about CF is that we know that no matter how well the patient is doing right now, that's just a short time before there'll be another crisis, another pneumonia, another hospitalization, and that these things are going to get more and more frequent and more severe. And then down the road, there are going to have to be some difficult decisions made about intubation, ventilation, extubation, discontinuing treatment, terminal weaning. Those sorts of questions are going to have to be handled down the road, and those are going to be hard for the patient and for the family, but they're also going to be hard for the healthcare professionals who have to actually perform those tasks. There are a few things more difficult that I can imagine than having to remove a breathing tube for a kid and watch that kid struggle for breath and die. It can take a huge toll on a healthcare professional and even make them wonder whether they want to stay in the business or whether there are other things they'd rather do. So CF is a difficult disease, not only for the patient and the family, but for the healthcare professionals who have to help make these decisions and then make those decisions turn into reality. Let's take a look at some of those end-of-life issues that the patient and the family have to deal with and see if we can understand a little bit better the emotional, spiritual, social issues that underlie these things. You're probably familiar with the idea of grieving as a response to loss, and you probably are familiar with the name Elizabeth Kubler-Ross and her book on death and dying, which looked at lessons to be learned from people who were grieving, mostly dying patients who were doing what was called anticipatory grieving, the idea that they are doing the work of their grieving ahead of time, thinking about a time when they will not be here, when they're losing progressively all these things, which is going to culminate in the loss of their life. The process that people go through is what fascinated Kubler-Ross, and she recognized that what people were doing was working towards the acceptance of death. Now, one of the things about working with cystic fibrosis kids is that they also are working toward the acceptance of their death, and they have to do it in a hurry because they're not going to have the luxury of growing old. So let's take a look at what this anticipatory grieving looks like as Kubler-Ross described it. Now keep in mind that we're not talking about hard and fast stages that people go through here. We're talking about experiences that people will have along the way as they travel the road of anticipatory grieving towards a destination that hopefully they will arrive at before they die, where they will have achieved a kind of acceptance, a kind of reconciliation of the idea that they are going to die. One of the first things that Kubler-Ross identified was that people who are moving towards this end process often go through a stage of denial. This is a self-protective mechanism. The brain does it in order to protect itself from something that is overwhelmingly threatening and destructive. The brain simply says, I refuse to process this. I just can't process this right now. I don't believe it. Denial can take a lot of forms. Sometimes people will say, I don't believe it. I want another opinion. I want another diagnosis. That those doctors are stupid. The lab tests are wrong. It isn't true. I'm going to beat this thing. I'll be the only person who has survived to a ripe old age with this disease. Whatever form it takes, denial is a roadblock to the journey that the kid needs to make in order to get to acceptance and the ability to say realistically, I'm not going to be here for much longer. Another obstacle that needs to be overcome on the road to acceptance of death is this thing called anger. People who are dying typically are angry. They're angry at God. They're angry at people who are not dying. They're angry at the doctors and the nurses. They're angry at their family. They're angry at everybody. And oftentimes the people around them who are the targets of that anger find it very difficult to take the anger. they take it personally. What they need to understand is that this person's not angry at them, he's just angry. He's angry at everything and everybody, and that's just something that he's got to work through in order to come to the place where he is able to say, I'm dying, I understand that, I can deal with that. A lot of those CF kids I saw were angry. They were being robbed of their childhood. They were being robbed of their future. They were being robbed of all their hopes and their dreams. Why wouldn't they be angry? A lot of the caregivers tended to take that personally and to mark those kids as hard to get along with, difficult, or whatever. And it is hard not to. When you're trying to do good for somebody, you're trying to help them, and they're angry with you, and they cuss you out, and they make it very clear that they don't want anything to do with you, that they blame you in some way. It's all too easy to just say, okay, forget it. But what we've got to do is to remember that they have a right to be angry, and that they're not angry at me. And I can handle that. I can absorb that. I can let them direct that anger because I know that that's just something they need to do in order to make the journey. Again, as you probably know, Kubler-Ross identified another obstacle that needs to be overcome on this journey towards acceptance as bargaining. People make bargains. They make bargains with God. God, if you'll just heal me, I'll be really good. God, if you just let me graduate from high school, I will give this or that. If you just let me get married, I promise to. Those bargains are ways of trying to control the final outcome, ways of trying to avoid the necessity of dying, a way to have some kind of control. And this is a normal part of the process and needs to be understood and accepted. And the person needs to be allowed to have conversations about why they're doing this and how they're doing it and what they're expecting to get out of it in order to be able to work through it. Another part of this journey lies through depression, and people who are dying typically experience a fair amount of depression. They are losing so much, and they get to the point where denial and anger and bargaining give way to a kind of sadness, a kind of emptiness, a sense of loss, a sense of hopelessness, a sense of helplessness. And that also can be very, very difficult to deal with. I've seen some of the kids with CF just kind of turn their face to the wall and withdraw and want nothing to do with anybody. They won't talk to anyone. They won't acknowledge even the presence of a friend or a family member. Depression can be a really powerful and negative experience. And like all of the other stages, about the only thing that we can do to help the person is to be there for them, to listen. If they want to talk, to talk. If they don't want to talk, to just be present with them and give them the ministry of our presence, and to listen and to relate and to allow them to go wherever they need to go and say whatever they need to say. For some very strange reason, that seems to help. We don't have to have good advice. We don't have to tell them anything. We just need to be there and listen and be accepting and non-judgmental and allow them to say whatever it is that they need to say. Let's turn our attention from the patient and family to the therapist, because the reality is that in dealing with CF kids, the therapist often has some real issues. And by therapist here, I mean specifically respiratory therapist, although certainly this applies to anybody who is involved in trying to give care to this child. One of the challenges for everybody in healthcare is to accept our own mortality. It is something that we don't want to do. We don't want to face the fact that we will die. And some of us run away from that fact, running scared. Some of us are much better at accepting it and being reconciled to it. It isn't something that anyone likes, but it's a reality that we need to face. So one of the things that needs to happen here is that we need to become reconciled to our own mortality and recognize that we also are going to die, and that death is not unnatural. It's a part of life. It's something that we all have to deal with, and it is a normal experience for human beings. Once we face that, then we are better able to deal with dying patients because we're not so terribly threatened as we are when we're running scared from our own mortality. One of the things that makes our pain worse in dealing with cystic fibrosis kids is that oftentimes we identify with them more strongly than we do with other patients. And part of that, especially if you're young, is because they also are young. And you tend to identify most strongly with those in whom you see similarities. So working with somebody over a long period of time also enhances your tendency to identify with them, and that exacerbates the emotion that you feel. The good part is that you're capable of higher degrees of empathy and sympathy. The bad part is that it hurts more, and you may find yourself hurting to the place where you don't think you can take it anymore, and so you try to separate yourself from the source of that pain, which means you also separate yourself from the patient. You may even decide that you want to separate yourself from healthcare altogether and find some other profession where you don't have to hurt so much. A lot of healthcare professionals find it very difficult to deal with dying patients. And part of that is not knowing how to help, realizing that the patient is going through an experience that they have not gone through, don't want to go through, have no personal knowledge of, and they don't really know how to help them go through it. And since we don't know how to help, we're afraid of doing harm. And so we think, well, I don't know what to say, I don't know what to do, maybe I'll just not say or do anything, I'll just stay away. And so the patient feels increasingly isolated and abandoned. That's obviously not the best solution. The best solution is simply to go and be there, simply to show up and shut up, and let your presence speak of your care and your concern and your compassion. You don't have to worry about saying the wrong thing or doing harm, because all that's necessary is just to be there. You don't have to say anything at all. Another thing that needs to be said is that we need to be okay with doing our own grieving. It's okay to cry. It's okay to grieve. You also have experienced a loss. It would be abnormal not to experience grief. I know that sometimes experienced clinicians will tell you that you shouldn't be feeling this so that you can remain objective and provide better care. I just don't think that's true. I think that, yes, you have to do your job, but I think that it's perfectly appropriate to grieve the loss of a person, a human being, a child of God, a brother, a sister, a patient. And that does good to the patient and to the family when they know that you care and they know that you're grieving. But you have to do your grief work. You have to work it all the way to the end. You have to do your crying. You have to go to the funeral, perhaps. You have to express how you felt about this and what you've lost. And only when the grief work is done are you ready to do it again with somebody else. You also, as a therapist, need to be aware of these phenomena called compassion fatigue and burnout. Compassion fatigue tends to increase the longer people have been in healthcare, and it's understandable. You go through some difficult experiences, you lose a little bit with every patient you lose, you hurt with every patient who hurts, and you only have just so much compassion inside, and eventually you get to the place where you just don't feel like you can care anymore. When that starts to happen, then you start approaching burnout. And with burnout, you find yourself working more and enjoying it less. You find yourself not doing the things that you went into healthcare to do. You find yourself dreading going to work. You find yourself detached emotionally. You find yourself experiencing loss of concentration, depression, perhaps broken relationships with people that you love. This is an emergency emotional, spiritual situation, and it needs some attention. It needs treatment. There are cures for compassion fatigue and burnout, and if you start experiencing this, you need to get some help from somebody who can help you to talk it through and work it through and get a new perspective on what it is that you're doing and what the meaning of your work is. Compassion fatigue and burnout are huge issues for healthcare professionals and seem to be becoming even more acute nowadays as healthcare professionals of all kinds experience less personal satisfaction, more discouragement, depression, boredom, and even increased rates of suicide. So this is a serious issue, and one that can really get you when you're working with kids who have cystic fibrosis. You really do take on their stuff, and you really do find yourself grieving. And if you don't pay attention to that and deal with it and do your work of grieving, you're going to get bit by compassion fatigue and burnout. If you're going to work with CF kids, I think you really need to pay attention to self-care. You need to take care of yourself and make sure that you're absolutely at your best, or you won't be able to give them good care. Just a few things to keep in mind here. First of all, you can't give another what you don't have. If your cup is empty, you haven't got anything to give. If you are burned out and strung out and depressed and your spiritual life is shot and you're filled with all kinds of anxieties and about God and about the meaning of what you do, then you probably haven't got much to give to somebody else. So you better go take care of yourself first, and then you'll have something to give. You've probably heard the expression on the airplane when the stewardess is giving the instructions about your seatbelt and all that stuff, and she comes to the part where there's the possibility of a sudden cabin depressurization and an oxygen mask will descend from the overhead. And then she says, "Put your own mask on first." This is an important piece of spiritual advice for health caregivers. You have to take care of yourself or you're not going to be able to take care of anybody else. If you don't put your own mask on first, then you're liable to black out from lack of oxygen, and then you will be a patient. You won't be able to take care of anybody else on the airplane. So put your own mask on first, and then you can take care of the people that you love and have to care for. And the same kind of principle works in healthcare, and too many healthcare workers don't put their own oxygen mask on first. They're too busy taking care of other people to take care of themselves, and that doesn't work. Not for very long. Do you know how to check your gauges? Do you know how to check your spiritual gas gauge and find out when you're running out of gas? Do you know how to keep your tank full? Quiet time alone with God, prayer, worship, reading scripture. Those kinds of things put gas in your spiritual gas tank and enable you to have something to give. If you neglect those things, if you're so busy caring for others that you don't think to care for yourself, then burnout is a very real possibility for you. And ultimately, of course, your patients and your family and your friends and you yourself will suffer. So keep your eye on the gauge. Don't let it get down into the red zone. Keep it full. Keep tanking it up. Find something that puts gas in your tank and do it. Find something that ministers to you spiritually, that encourages your soul, that refreshes you, that recreates you, and make sure that you do that. Don't neglect it. Your patients deserve it. There's a verse in the Bible that has always meant a lot to me, Proverbs 4:23. It says, "Above all else, guard your heart, for from it flows the well springs of life." Above all else, before you do anything else, make sure that your heart is full. Make sure that you make space to be alone with God, to refill your tank, to recharge your batteries. to do whatever it is that gives you new life, new strength, new hope, new courage, new faith, new optimism. If you don't do those things, then you are cutting off the well springs of life. You're neglecting your heart. And sooner or later you will suffer for that, and so will those who love you and those who depend on you. Kids with cystic fibrosis bring a lot of sadness. And in order to minister to them, you need to be spiritually full, emotionally rich. You need to come from a place of serenity, a place of peace, and a place of joy. So take care of yourself. It's just as important as learning the techniques that go along with caring for them. You must be a healthy person in order to be a healer. You can be a wounded healer. That's okay. But you must have something, or you won't be able to give.